So today we are going to read about Kawasaki disease. Kawasaki disease is an important core topic of pediatrics. Kawasaki disease is medium vessel vasculitis. That is, it involves a medium-sized vessels, which mostly includes the coronaries. Its incidence, it is more common in Japan, then South Korea, then Taiwan, and in India it is common in Chandigarh. Male to female ratio is 1.5 to 2:1. That is more common in male as compared to females. And also it is uncommon below 6 months because of some maternal antibodies which are transferred to the baby, and also it is less common above 5 years. So it is usually common between 6 months to 5 years. Below 6 months not common, above 5 years usually scarlet fever is a differential diagnosis. Kawasaki won't be there. Next comes etiology. First is some immunological reactions may occur between the antigen and the host, and it can also be like some infective etiology, like some infections like fever and rashes. All these are usually seen in infections, so it shows some infective etiology. Then some theories are there which also like put forward this view of super antigens, like because its pathophysiology is somewhat similar to toxic shock syndrome, that also has super antigen. Next comes the genetic basis, because it is more common in siblings and also children of patients with Kawasaki. So if your sibling has Kawasaki or if your parents have Kawasaki, then you have more chances of getting Kawasaki. Then comes what is the pathology. First of all, neutrophils will be there, we know. Necrotizing neutrophilic arteritis, which will lead to ultimately inflammation and vasculitis, which will ultimately lead to myofibroblastic lesions. First neutrophils, then obviously it will lead to that inflammation and vasculitic lesions, all that. Then muscles, smooth muscles will be there, so myofibroblastic lesions. Then finally this enzyme matrix metalloproteinases will be elevated, ultimately leading to aneurysms. So coronary artery aneurysms is the main feature of Kawasaki disease. Next comes clinical features. So clinical features, this is very important in Kawasaki. So what are the clinical features? First, fever for more than 5 days will be there, and with fever for more than 5 days, at least 4 of these 5 features should be there, at least 4. Now, what are the 4 features? First, extremity changes. In the initial stage, erythema of palm and sole. In the acute phase, that means redness will be there in the palm and sole, which will ultimately lead to edema of hands and feet. And in the subacute phase, you will see periungual peeling of skin, as seen like this. Periungual peeling of skin will be there. Then rashes will be polymorphous and never vesicular. Vesicular means fluid-filled lesion. So it will never be fluid-filled, it will be polymorphous. And in conjunctiva, bilateral bulbar non-exudative conjunctivitis. Very important, non-exudative. Next, lip cracking, erythema and strawberry tongue as shown in the picture. And last, cervical lymphadenopathy unilateral and more than 1.5 centimeter, at least one node. It is the least common features, lymphadenopathy. It won't be seen in all cases. So what will be seen? Erythema, and like you can remember it with cream. This is the mnemonic. And what will be seen? Cervical lymphadenopathy, rashes will be there, edema will be there, and lymphadenopathy will be there, and this non-exudative conjunctivitis will be there. This is strawberry tongue. This is the periungual peeling. The next comes what is the lab test? What are you going to see? So in lab test, you will see leukocytosis and neutrophilia. That means neutrophils will be raised, TLC count will be raised, ESR will be raised, anemia will be there, thrombocytopenia initially, then after 1 week thrombocytosis. Raised CRP because it's infection, raised liver enzymes, decreased albumin and increased plasma lipids. LDL and this triglyceride will be raised, HDL will be low, hyponatremia, sterile pyuria, CSF, you will see mononuclear pleocytosis. Then next comes 2DECO. In 2DECO, when it should be done? This is important. At diagnosis, when you diagnose it is Kawasaki, then at discharge, then after 2 to 3 weeks, and then after 6 to 8 weeks of the illness, it should be done. Then another investigation is dual source CT coronary angio can be done. Okay. Then next comes incomplete Kawasaki. What is incomplete Kawasaki? If fever more than 5 days, but less than 4 of the classic clinical criteria. In Kawasaki, fever more than 5 days plus at least 4 criteria. In incomplete, less than 4 criteria. Atypical means patients with symptoms and signs which are not seen in Kawasaki, like nephritis. Then what is the treatment? Treatment you will give is IVIG 2 gram per kg over 12 hours should be given, and aspirin. In acute phase, you will give 30 to 50 mg per kg per day, and in the convalescent stage for 6 weeks, you will give maintenance dose of aspirin 3 to 5 mg per kg per day. But the main treatment is IVIG then and aspirin. So IVIG and aspirin is the treatment. Okay, the next comes complications. What are the complications? You will see myocarditis, valvular involvement, aneurysms, Kawasaki disease shock syndrome, thrombosis can happen, stenosis can happen, that aneurysm can even rupture. The next is resistant Kawasaki. What is resistant Kawasaki? If even after IVIG treatment completion, even 36 hours are later, still if fever persists more than 30 degrees Celsius, that means that is resistant. It will have more chances of aneurysm. Sodium will be less than 133, liver enzyme more than 100, this AST, and neutrophil more than 80%, CRP more than 10, more common in age group less than 12 months, and platelet less than 3 lakh. And day of illness at initial IVIG less than 4 days. That is resistant Kawasaki, not responding. This image shows like how a Kawasaki child will look. You will see these rashes, this strawberry tongue, this lip erythema and cracking of lips, this periungual peeling of extremities, and bilateral this non-purulent conjunctivitis.